Thank you for joining us for this learning series webinar, The Role of Medication for Opioid Use Disorder in Fighting the Opioid Crisis. Today's webinar is brought to you by the Partnership for a Drug for New Jersey and is being held in collaboration with NJ Cares and the New Jersey Office of the Attorney General. And I thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. I'm so pleased to introduce our featured expert speakers with us today for this very important conversation. We have Dr. James Baird, founding emergency medicine residency program director and a practicing emergency medicine physician at Inspira Health, Medical Hill. He's also the associate professor of emergency medicine at Rowan University School of Osteopathic Medicine. He's the medical director of the Medications and Addiction Treatment Program at My Friend's House Treatment Center in Woodbury Heights, and he's the medical director of education for Gloucester County EMS EMT Training Academy. Thank you, Dr. Baird, for being with us today. We have also with us Dr. Herbert Caldani. He is the New Jersey Department of Corrections Director of Psychiatry, Addictions, and Medical Services. Thank you as well, Dr. Caldani, for joining us today. And we have Tim Saplacki. He is the Chief EMS Data and Intelligence Officer at the New Jersey Department of Health Office of EMS. Thank you, Tim, for being with us today as well. And we will get started. Dr. Baird, I will turn the presentation over to you.
All right. Thank you very much, Angela, and welcome everybody. I'm here to talk to you today about what is MAT? What are these medications that we're talking about? My credentials are there, and next slide, please. So let's define what addiction is. What is this disease that we call substance use disorder? What is MAT and how we use it for opioids, the three main types of these medications, and how do these medications help people who are suffering from an opioid addiction? Next slide. So why do people use drugs? I think we often forget that, there's an underlying reason. We're focusing on the person, in my case, in colleagues' case, the patient. We forget that there's a whole reason behind people using drugs, whether that's to feel good, to feel better, to do better, curiosity, experimentation. There's a whole spectrum of why people use. When it comes to the opioid crisis and really the overdose crisis, we're really looking at the people who do it to feel good and to feel better. Next slide, please. So what is addiction? Let's do a crash course in addiction as a disease model. Substance use disorder, a very complex condition, multiple variables with each individual who suffers from this disease. But it's defined by uncontrolled use of a substance despite harmful consequences, and often despite knowing there are harmful consequences, but continuing to use. People with substance use disorder have an intense focus on using a certain substance, alcohol, tobacco, street drugs, to the point where it affects the person's ability to function day to day, and life essentially becomes impaired. And again, the emphasis is they keep using the substance even though they know it's causing or will cause them problems. Next slide. So we have to look at why. So let's try to dive down and look at what effect does pleasure have on the brain chemistry. So I'm trying not to get too nerdy here and keep the science minimal, but it all boils down, every addiction boils down to dopamine. Dopamine, which you may have heard of before, is a neurotransmitter. It's essentially a chemical made by our bodies, and it is released that creates the reward. The reward circuit is activated by any sort of healthy, pleasurable experience. You get this burst of dopamine that signals that something important happens, and you remember that. Eating food when you're really hungry, getting a raise, getting your paycheck. Anytime that you feel that good surge of positive energy, there's dopamine behind that. It's a natural phenomenon. When dopamine signals, it causes changes and it increases these nerves, connectivity. Essentially, think of it like we're paving a gravel road. So we're paving this road, which makes it easier to repeat that activity time and time again without even thinking about it, which subsequently leads to the formation of habits that we have. Next slide. So this is an example of what dopamine looks like. So sort of on the top and the bottom part of the slides to the right are these nerves, and dopamine are these little sort of yellow orangish of balls of energy going back and forth that get released. And on the left, this is while eating food. On the right, and this is why drugs are essentially so effective at increasing dopamine, upwards of around 10,000 times the amount of dopamine gets released into these nerves that cause it to fire. So you can see the power essentially that these street drugs have on the pleasure center of the brain. Next slide. So why is this effect so different? Again, you get this intense euphoria. So, you know, not only are we paving the road, so to speak, if we want to use my prior analogy, but we're doing a 4-lane highway here because of the large surges of dopamine. These are powerful, reinforcing connections between the consumption of the drug, but also the pleasure and all the external cues that happen to that experience. It teaches the brain to seek drugs at the expense of other healthier goals and activities. So somebody who's using, it's not just using the drug in the field, it's everything around them. It's the environment, it's the basement, it's the bedroom, it's the people with you, it's driving to the corner to cop your drugs. It's everything that goes along with it that ties to this intense sort of habit forming connectivity in your brain. And all these cues become linked with drug use, reward circuit, and uncontrollable cravings whenever the person is exposed to these cues. Even if the drug isn't there, it's this learned reflex that happens over time. So I'm going to give you an example. So just as a little background, I'm a community ER doctor as well as a community addiction medicine doctor. So caring for these patients, I hear this time and time again. I'm going to give you a specific example of a young gentleman who was addicted to heroin approximately 5 years ago. Tried everything, all forms of treatment, could not stop relapsing. So he moves out of the area, moves down to Texas, is there for 5 years. He tells me he never even thought about drugs, never got a craving, nothing. His mother got sick. He's coming back to the area. As the plane was descending into the Philadelphia airport and he saw Camden, he got sweaty palms, he got anxious, his heart started to race, his mouth started to water. So these cravings can last a long time. Nothing is technically forever, but you know, we're not really sure about how long these last, but they are that powerful. Next slide. Every disease has protective factors and risk factors. Addiction is not spared in that paradigm. So protective factors, positive temperament, a good social support system, you're in a caring relationship, you have an education, you're employed. All these things actually can protect an individual from getting an addiction. And put this slide on here. The most common question I get is, why them and not me? Why me and not them? We all talk about how we all grew up in the same neighborhood, but there's one person who ended up with an addiction. Why that person? We had the same sort of environment that we grew up in. Well, there's different risk factors. So there's individual risk factors, the biggest being genetics, mental health disease, behavioral health disease. You live in a neighborhood where everybody does drugs. There's a high rate of crime. Drugs are easy to get. Being part of a vulnerable group. Again, having mental health, or your parents misuse drugs, there's abuse within the family, multiple risk factors. Again, you only need one of these or all of these, but everybody is different, and really talking with somebody with an addiction and getting down to the root of it is key. Next slide. So what results? Distorted thinking, behaviors, cravings, changes in personality. Brain imaging studies I'm going to show you briefly related to judgment, decision-making, learning, memory, behavior control. All of these things are negatively affected when somebody has a substance use disorder or an addiction. And repeated use emphasizes that. And these changes, again, can be long-lasting. Next slide. So here we have examples of brain scans, what we call functional MRIs or PET scans. So the red areas of the brain to the left and the, quote, normal brain, which is the non-addicted brain, these are the areas where dopamine receptors live. Dopamine receptors, because of the large rush of that, they get downregulated. You can see in cocaine and even obesity, people who are addicted to food have the same brain changes here. These areas of the brain essentially shrink, which causes, next slide. So the downregulation of these receptors. So those red areas shrinking leave people who misuse these drugs without motivation. They appear lifeless or depressed, and they don't enjoy things that were previously pleasurable. So now the person continues to take drugs to experience just a normal level of reward, which only makes their underlying problem worse. Next slide. You can see here, there's multiple examples of cocaine, methamphetamine, alcohol, heroin, which have the same effect on the brain. And as people take larger and larger amounts, they develop this tolerance. Next slide. So the frontal lobe, right behind our forehead, is the area of the brain that's responsible for decision-making, response inhibition, planning, memory, and the metabolism of that is shown here in a non-addicted brain up top versus someone who is addicted to cocaine. And you can see that the metabolism is lower in that frontal cortex. There's multiple studies that show this and show that just the general activity of the brain is diminished in somebody with an addiction. Next slide. So MAT, you're going to see some different terminology coming out. Medications for addiction treatment or medication for opioid use disorder. Just want to make you aware of that. Next slide. So what is MAT? MAT is the use of medications in combination with counseling and behavioral therapies, which gives you the whole patient approach. So we are using medications. I use the three-legged stool sort of analogy here. Your recovery is on top of a three-legged stool. That stool will fall over if any one of the legs gives out. You have one leg being medication. You have another leg being counseling and behavioral therapies. You have another leg, which is peer recovery support, AA, NA. Each one of these shares an equal power in keeping that recovery on top of that stool. You remove one of those, you're at risk of a relapse. I have to emphasize that medications are part of the solution. So these medications will normalize this brain chemistry, block the euphoric effects of drugs, they relieve cravings, they normalize bodily functions. It gets rid of all those negative effects of withdrawal and also without any negative effects of the actual misused drug. Next slide. So these medications work in several ways. Looking at the bottom here, Naltrexone, purely a blocker. This prevents people, if they use a drug, it prevents it from attaching, so there's no effect. So if you're on Naltrexone, Vivitrol would be the other name. You get a monthly injection. You can use heroin, opiates, you're unlikely to feel anything. Buprenorphine, or what's called Suboxone, will bind to this. It will help alleviate cravings, will also essentially, have a big safety profile of preventing you from overdose. And Methadone, similar, but it's what we call a full agonist. I'm going to let the next speaker kind of talk more about that specifics, but there are those three main types right there with those three main functions. Next slide. So everyday drugs suppression, the craving is the seed that grows. It's what leads to the slip, what leads to the full relapse. And that's where the medications come in. It helps prevent those daily drug cravings that you get. Next slide. So here's the analogy. Type 2 diabetes, defined by the American diet. Excessive carbohydrates leads to diabetes. So should we just tell Americans to stop eating? How many people can do that? It's a major behavioral health problem. So we use these diabetes medications because they decrease heart attacks, strokes, high blood pressure, high cholesterol, infections, death, all these benefits from these medications. MAT has the same effect on addiction. Next slide. The benefits are, the bottom line, it improves patient survival, it decreases overdose, deaths, it decreases the amount of drugs that people use and other risky behaviors, it decreases trading sex for money, IV drug use, people stay in treatment longer, it decreases criminal activity. We know that drugs drive crime, it increases the patient's ability to gain employment, improves birth outcomes, lowers a person's risk of contracting HIV, hepatitis, and just improves overall physical and mental health. Next slide. So my references are here. And before I end, I'll just say MAT, the main point of this, it is a life-saving medication in this population currently. 60 to 70% of people are going to be alive in a year if they're on MAT versus those who are not when they're suffering from an opioid addiction. So this is why you're seeing MAT pushed a lot. You're seeing it a lot because the evidence is there. I look forward to answering all of your questions towards the end, and that's all I have. Thank you for your attention, and I hope this helps.
Thanks so much, Dr. Baird. I think the information you gave was so important. And I know there were a lot of questions that came in from the chat. So we'll hold those until the end of all the presentations to get back to those. But thank you. Dr. Caldani, now I will turn the presentation over to you.
Thank you, Angela. I appreciate the invite to be here and everyone at NJ Cares for creating this forum. I do hope that folks will notice that some of the information that I'll be presenting will be somewhat similar to what my colleague Dr. Baird presented. And I think that that reflects that there's a convergence on the science between the perspective of mental health, such as myself as a psychiatrist, and that of physical health as presented by Dr. Baird. And that convergence truly benefits our clients, our patients, because the approaches begin to be more consistent, whether they include medications, whether they include talk therapy as part of the three support systems or legs of the stool that Dr. Baird discussed, and peer supports. And I will focus a little bit more on the correctional aspects when it's applicable. And I just want everybody in the audience to know that in the Department of Corrections, we offer all three of those legs. We offer peer supports, we offer psychosocial treatments, and we offer the entire array of medications that are used in opioid use disorder. Next slide, please. So we have a short period of time. I'll go through what our mission is. I'm going to focus a little bit on the New Jersey Department of Corrections experience, how we shifted from opioids being used for pain management to addiction management. Whenever we talk about addictions, I emphasize that we need to talk about a few other things that are related to addiction, pain management being one of them, because many people begin to experience addiction through prescription opioid that are prescribed for a physical problem or other issue, and then it leads to addiction. Our first objective is I'll review some of the data from how in corrections we shifted from opioid use and pain management to addiction treatment. I'll review a little bit about the impact on laws on addiction. I'll have similar pictographs to Dr. Baird regarding some addiction, so this will be good in terms of re-emphasizing the science behind it. I'll talk a little bit about the culture shift here in the Department of Corrections, and then the general shift in our view of addictions in law enforcement overall, and then talk a little bit about that shift in the perspective of addiction in the community, and how we have to deal with bias. Some people still view addictions as something that is not seen as a medical disorder, and this is where we really need to emphasize that this has biological medical origins with an overlay on psychological and behavioral outcomes. Next slide. So I want to jump to the very end of the experience in the Department of Corrections, which is I put together some slides on the data in the department here. And if you can see the slide on the left, it talks about the illicit versus prescribed opioids. So we randomly test the incarcerated population every week. And over a period of years, in the solid green section there, you'll notice that what we were prescribing was a very large amount of prescriptions. And then in the shaded or straight line area above that graph, that's what was being illicitly used. And so you could see that the number of people who were using opioids in the early years, 2015, 2016, was very high. And over time, what I want this graph to impress upon you is that we began to make an effort, a concerted, intentional effort to first decrease the amount of opioids that was prescribed. And that is where the solid shading you can see over time really drops down. And along with that, you can see that the illicit drug use also drops down. And in 2021, our rate of seeing people in corrections using opioids that are prescribed or illicitly using prescribed drugs has tremendously dropped. And this is really a reflection of the good work of all the clinicians working here in the Department of Corrections. On the right-hand side, I want to point out that we made a concerted effort to begin prescribing MAT, particularly buprenorphine, and that started along the time that we saw um, with the reduction in prescribing opioids. In other words, we did both things, but not simultaneously. First, we addressed the decrease in opioid prescriptions. The second thing that we did is we began to increase the use of buprenorphine. And you could see around 2017, 2018, that the solid shaded area is the amount of people who were testing positive for buprenorphine and who were prescribed. And you could see that over time, that number rose. And we had at one point prior to the pandemic over 1,000 people on buprenorphine. And then the lightly shaded area is a number of people who were illicitly using Suboxone. So we still have people that are diverting Suboxone within the system. But even though we increased the number of people on buprenorphine, the percentage of people who were illicitly using Suboxone remained very low. You could see in 2015 and 2016, all of the buprenorphine in our system was illicit, and then we began to prescribe it, and it has made a significant difference in outcomes in the Department of Corrections. Next slide. If I were to combine both of those graphs, you see that here on this slide. I just wanted to show you the comparison in true numbers. The previous slide made it seem that the amount of opioids prescribed and the amount of buprenorphine prescribed is almost the same. But when I take the numbers and I make them exactly equal on the scaling, you'll see that the amount of opioids that were prescribed is still very, very much lower than the amount of MAT that we were prescribing. And that is a significant improvement in our system. Rather than to continue to see people be addicted to opioids, we've got them into treatment on buprenorphine. Next slide, please. So some of the laws that affected the prescription of opioids in New Jersey in 2017, the first prescription had to be more than 1 year since the initial visit, and every medication had to be reviewed by the physicians through the PMP, the Prescription Monitoring Program. And you could only use immediate release. You were no longer permitted to use a long-acting opioid. You had to use the lowest effective dose in a maximum of 5 days. If you needed a second prescription, the pain had to be consistent with the first prescription, and 4 days had to have elapsed so that you were on the 5th day, again, reviewing it. The reason for the review is to see that your patient is not doctor shopping and trying to get medications from different prescribers. So that was an excellent tool for physicians to see how severe the addiction was. Simply because somebody was going to different doctors doesn't mean you don't treat them, but it alerts you to that potentially this is the start of an opioid addiction. And this was a great law, in my opinion, in helping physicians to really curb their own prescribing habits and also to help patients to address and be more candid about their own potential addiction, which was starting from an opioid prescription. Next slide. So in corrections, as Dr. Baird mentioned, we do use the 3 types of medications, methadone. So methadone was a federally regulated program starting in the 1960s. Generally, folks are on about 80 to 120 milligrams every day, and it has been shown to decrease overdose deaths. And as Dr. Baird mentioned, many factors in terms of psychosocial adjustment. It reduces criminal activity and decreases rates of HIV and hepatitis. In corrections, we tend to see doses that are a little less than the 80 to 120 milligrams. And I'll explain that in a minute when I get to buprenorphine. So we also prescribe buprenorphine. Typically, the community dose is 8 milligrams twice a day. in the correctional system, I think our average is somewhere between 6 milligrams and maybe 12 milligrams. And buprenorphine has been FDA approved since 2002, and providers need to be a Data 2000 waiver to allow this prescription to be offered in an office-based setting as opposed to going for methadone at a methadone clinic. And here's the reason why both of these doses are lower in the correctional system. The majority of people who come to the Department of Corrections have been physically de-addicted from opioid use. For example, most come through the jail system and what's called forced withdrawal. They are either not able to get their opioids, and so they go through a withdrawal, or the jail is able to start them on MAT. However, we still see that the great majority of people coming in through the jail system into the state system are not on any treatment. And what happens then is their body changes. When a person is addicted, whether it be alcohol or opioids, their body begins to metabolize or chew up that drug much, much faster. Their liver learns to metabolize those drugs much better. This is why you'll hear the expression, I could drink it under the table. That's because the person who's regularly drinking, they're able to metabolize the alcohol. The same is true of a person who's using opioids. They're able to metabolize the opioids much faster. Once they're physically done with the withdrawal and they are physically de-addicted, we still feel that they need treatment. And so we end up starting them on lower doses of MAT, and that is why we see the average doses in corrections are lower. Their liver is no longer able to metabolize the medication or the drug like it did when it was seeing it every day. That's the reason why the doses in corrections are generally lower. We also use Naltrexone for people who opt to go in the route of decreasing usage by having a blocker. But we find that most people in corrections will choose either methadone or buprenorphine. And part of that is that they have exquisite ability to reduce cravings. So in the community, when somebody started on MAT, we generally titrate the dose to reducing the withdrawal symptoms. As I mentioned in corrections, the person is done with withdrawal, and yet we start them on the medication to help their brain heal. And that is the reason why we started, and that is the reason we started at a lower dose. Next slide, please. So hopefully you're getting the idea that this is a brain disease. It's a brain disorder. When we treat the brain, we see that behaviors do change. They do shift. I do want to point out that although it was a nice saying to just say no, the Just Say No campaign was a gigantic failure. If we could just have everybody say no, we would have no addictions at all. Everybody would be able to say no. As Dr. Baird mentioned with the analogy with diabetes, it's a wonderful analogy. In the emergency room, when somebody comes in with diabetes and we treat them with medications, including insulin or oral medications, we lower their sugar. You would never hear the doctor then say, okay, go home and just say no to sugar. It's impossible. So we really don't want to do that with people who have addictions. We don't want to just say to them, just say no to drugs. It's just not possible. So this idea of whether addictions is a choice or part of our willingness or fortitude to just say no is a fallacy. And that is where the science has proven that part of addictions is that you really need to think hard about whether you believe that addictions is a choice. As a scientist, as a physician, I really don't think it's that simple anymore. It's not a black or white. Can I just say no? If that were the truth, then everybody would be cured by now. So I think it's more than just a choice. And this is why we consider it a brain disease. Next slide. So I'll zoom through these slides. You've seen them a little bit earlier from Dr. Baird, where we have the reward center based on our knowledge that the reward center, through the use of dopamine, there is what starts the addiction. I do want to point out, though, that in that part of the brain, the prefrontal cortex behind our forehead, as Dr. Baird mentioned, is where the judgment center is. And that is now known, if we switch to the next slide, please, to send signals and fibers from the reward center to the prefrontal cortex. And in essence, continued drug use seems to be damaging. I can't even say seems. It does damage. This is what we now know. It damages that area of the brain that is involved in decision making. Next slide. Normally, that decision making part of the brain in the prefrontal cortex send a signal back, okay, like with food and other things, this is a good thing. Take a little bit of that, you feel good, and then stop. But with continued activation of the reward center, it overrides the prefrontal cortex and it damages the prefrontal cortex so that the ability of your mind, your brain to then say, okay, enough, that's stopping, the ability to say no is greatly diminished. And in some people, in fact, it stops completely. They're unable to say no. They're unable to stop. This is the science behind why addictions is no longer viewed as a choice. And let's go to the next slide. Similar to what we saw earlier, these are the MRI scans of healthy children. This is part of what is so unfortunate about addictions in our younger population. The area in red, you could see there with the white circle, that is the area of decision making. It's in the right-hand side of the brain in that prefrontal cortex behind our forehead. In children age 5, the red means that it is undeveloped. That's why children need guidance from parents. They don't know too much about right or wrong or how to stop. And over time, you can see that it takes quite a bit of time for that area to fully develop, and then it goes from red to yellow to green to blue. And you see the white circle there at age 20. And unfortunately, this is to show how addictions is very common in young people because that area of the brain which develops in the prefrontal cortex isn't fully developed. So they are tempted via peer pressure or other things to start to use medications and drugs, and they don't have the ability to say no, even if they wanted to say no, because that area of the brain is underdeveloped. So it's just to show you how over time that area that allows it to make good decisions takes a long time to develop. Next slide. I really want to follow up on what Dr. Baird said in terms of natural rewards and dopamine and what he talked about. I'm going to show you some specific slides to bring home the message. We talked about food. So this was done in animals. So I just want you to know that although this was done in animals, there have been tests replicated in humans, but the graphs that I found are most particular to animals. So you can see we all start with a basic amount of dopamine. We used 100 as the baseline, and food increases that feel-good neurotransmitter of dopamine greatly. It spikes within an hour to 150, and then it takes about 3 hours for it to get back to the baseline. So food has the ability to cause that addiction process. Sex, on the other hand, interestingly, is even more powerful. You could see that the initial surge of dopamine within 2 to 3 hours is 200, which exceeds food. And yet it continues to have a release of dopamine lasting up to 8 hours. So that Darwinian evolution of procreation is built into our neurocircuitry. And that is what we see when we look at the science. Next slide, please. Now I'm going to bring in a couple of drugs for you to see on that same scale. Morphine is listed there because indeed, when somebody uses heroin, the heroin is converted in our body within 3 to 5 minutes into morphine. So it is very difficult to say a person overdosed on heroin because when our research labs test for heroin, it is all converted to morphine. So just so that folks in the audience know, it is implied that if you see a high dose of morphine, unless they had a prescription for morphine, most people who overdose from heroin, we see the morphine level go high. And that's why we measure morphine, and you could see that it looks a little bit like food in that it jumps up to 200 and it lasts a long time. If we go to cocaine on the right-hand side of the graph, that exceeds morphine. So the dopamine surge goes all the way up to 300 and 350, and then it tends to come down over 4 to 5 hours. I put nicotine on here just to emphasize how addicting nicotine is. Look at that initial surge of dopamine is extremely high, close to 225, which is more powerful than food and more powerful than sex, and it stays elevated for a number of hours. So our clients, our colleagues who are addicted to cigarettes and other nicotine products, you now know why. You've seen this graph. It is extremely dopamine inducing, and that is why it is difficult to stop smoking. Alcohol is there. You can see it goes up to 200, and then within 3 to 4 hours, it also drops. I do want to emphasize that not all of these slides reflect that. When we talk about that prefrontal cortex, the dopamine is not what is being involved at that point. What is damaged is other transmitters, particularly glutamate. And we'll get to that in a minute, but I just wanted to highlight that. Next slide, please. So here's the most damaging medication, although we're talking mostly opioids. I did want the audience to see amphetamines because we're seeing a rise in amphetamines. Look at this elevation in dopamine. It's 1,000. This is by far the most addicting drug that we see these days in terms of the release of dopamine. And it takes 6 hours for it to come below 200. We are seeing it in the big cities. Amphetamine and methamphetamine is even more powerful than amphetamine in releasing dopamine. So I just wanted to give you a scale of the different drugs as well as some natural things on the release of dopamine. Next slide. In an article, June 5th in the New York Times, you could see that drug overdoses per year from 1980 to 2016 have increased. It's 64,000, by far exceeding the effects of car crashes, HIV, and guns. So just to give you a scale of the problem that we're dealing with. Next slide. Some national trends, we see that drug overdoses are the leading cause of death in Americans under 50 years old. And back to my point about 80% of new heroin users first misuse prescription opioids. Again, why we need to talk about pain management whenever we talk about addictions. Next slide. And in the DOC, we started in 2014. I showed you the graphs at the beginning by reducing opioid pain medications. We shifted from a more therapeutic community model to a more holistic medical model, introducing the use of medications for addictions, MAT or MOUD, however you're comfortable using the term. We opened up a licensed substance use disorder treatment, which is ASAM adherent. That's been since 2015. That is the talk therapy side of the ledger in terms of we have medications, peers, and talk therapy. We've had MAT such as buprenorphine since 2017. We still see some clinical bias, both by clinicians as well as the incarcerated population. There's still hesitance to try medications. And our peer navigator program has been a huge success. All of the peers support the use of MAT, even though themselves are in recovery and yet may not have gone through MAT. They support everybody in our prison system to seek the use of MAT so that it is a synergy with the talk therapy and what the peers do. So this is where the three legs of support come together: the peers, the medications, and the talk therapy. We did train all of our custody staff as well as our clinicians together so that we would decrease that bias that people have. Next slide. And overall, in law enforcement, drug court in 2014 did not offer MAT until 2017. It now offers it, and we see a tremendous diversion of people into treatment prior to coming into the prison system. We also see that at the jail level, several jails, including Atlantic County Jail and Morristown County Jail, offer methadone, and other jails are expanding the use of MAT. I've been integrally involved in that collaboration with the Department of Health and the Department of Human Services through DMOS in increasing the use of MAT in the county jails. It has been very successful. I will skip the rest and go to the next slide. And we see, as evidenced today by the presentation by Dr. Baird about the use of MAT, even in the emergency room, the shift in the treatment of addictions rather than pain medication. And I have personally seen more and more rehabilitation centers now include MAT as part of their recovery, whereas 5 years ago, I can tell you that most recovery centers did not incorporate MAT. They certainly are doing so now. Next section. And so this slide really just talks about the connections between the community and corrections, because everybody in corrections ends up back in the community. And so the community, as I've mentioned earlier, they divert people now. When they come to corrections, I have a funny word in terms of we try to convert them into being medication compliant or treatment compliant. And then we have dispersion where we release them back into the community where hopefully they can continue their treatment. And so this is the connection between jails, prison, and the community. We work closely with our friends in parole and reentry to ensure that they get follow up with somebody in the community if they are on MAT. Next slide. Please note that there's a 129 times risk of death within the first 30 days of release from a jail or prison, and this is either to suicide or overdose. Many of the suicides are via overdose, and our peer navigator program has been very helpful in decreasing overdoses for those that receive those services. We provide a ride home for released incarcerated people. We actually have the peer drop them off at home so that they don't accidentally or intentionally come across their drug dealer and undo all the good work that they do here. We also provide them a phone, a smartphone, so that the peer navigator can check in with them via text messages. We certainly support the reduction of HIV, sexually transmitted diseases, and hepatitis by using this holistic harm reduction approach. Next section. Well, that's it. Thank you. And I look forward to seeing the questions at the end of the forum.
Great. Thank you so much, Dr. Caldani, for that information. Tim, I'm going to turn the presentation over to you.
Great, thank you so much. So again, my name is Tim Splacki. I'm the Chief of EMS Data and Intelligence for the Office of EMS in New Jersey, and we also obviously oversee a lot of the opiate initiatives for the pre-hospital providers. I'm just going to talk a little bit about it and just kind of expand upon medication-assisted treatment and how it's kind of rolled into the pre-hospital realm, into our emergency medical services clinicians and how they are rolling it out into the community. Next slide, please. So just a little bit of understanding, New Jersey has a unique EMS system. They have a tiered system of response. You have your local community-based basic life support, which is your local ambulance with EMTs. They're staffed by all the local communities. There's probably about 400 or so around the state. There's about 24,000 certified emergency medical technicians within the state. And then from a more advanced level, there's advanced life support paramedic units, which provide paramedic intercept. That's the vehicle below. You may have seen them on the road as well. And the idea behind it is they were only dispatched to life threats. So there is about 15 paramedic programs around the state. So what happens, I always use the example, if somebody falls out of a tree in a local town, they'll send the local community basic life support. If the person falls out of a tree and they're unconscious, then they will send the local ambulance as well as the regional staffed paramedic unit, which may be covering 5 to 10 towns. The idea behind that is obviously the more advanced care medications is being offered by paramedic unit, and they're in constant touch with a physician back in the emergency room. Next slide, please. So some of the statistics with the overdose response for EMS, New Jersey sees about 8 deaths a day linked directly to opiate overdoses. Our first responders treat about 35 overdoses per day. Last year, we treated over 9,500 overdoses around the state. One of the things that a lot of people don't realize is that up to half the patients that emergency medical services treats will actually, once they're reversed with naloxone, they will refuse further treatment or transport to the hospital. In New Jersey, if the patient is alert and they're oriented and they're able to make decisions and they're not at risk themselves or others, then they do have that right to refuse transport, and that very often happens. From the emergency medical services standpoint of view, they're taught to treat the physical symptoms. So when we talk about things like stigma or chronic diseases, that's a relatively new concept to emergency medical services, and one that we're trying to work on and obviously expand the role of emergency medical services beyond just the ventilating the patient, giving them naloxone to reverse the overdose, and then asking them, do they want to go to the hospital? Yes or no, and no. And then obviously that cycle continues and continues. So EMS plays a critical role in breaking that cycle of constant overdose, wake them up with Narcan, overdose again, wake them up with Narcan, and try and get them the resources that they need so they can move beyond obviously just that cycle of overdose. Next slide, please. So knowing that EMS is very often, in a lot of these cases, the only medical professional that their patient's going to see that day if they're refusing transport, EMS many times will treat the same patient over and over and over again, and they wonder, well, same patient, we keep seeing over and over and over again. How can we break that cycle? So it's training EMS to understand substance use disorder, like we said, as a chronic disease. We've developed in 2019 a program called the 5 Minutes to Help program, and the idea behind 5 Minutes to Help is aimed to address that stigma. It changes the way that the first responder views that patient rather than a user, burnout, junkie, and changes them to, chronic illness, understanding SUD, active listening, provider wellness, patient wellness, and just changing the overall, doing a paradigm shift on how the overall treatment of those patients are. They're no different than any other patient with a chronic disease. We have trauma-informed care to understand where a lot of the overdoses come from, how mental health plays a role in it, not only in the patient, but also in the provider themselves. And then making sure that EMS has resources to give to that patient. So if the patient chooses not to go to the hospital, that they still have other options to get recovery services such as Reach-NJ or other harm reduction services around the state. So we want to make sure that our EMS providers are equipped with those resources to leave with the patient. So next slide, please. So there was 2 laws that were recently passed last year. 153 was actually permits paramedics to administer buprenorphine. We were talking about buprenorphine or Suboxone earlier on in this program, in this panel discussion. New Jersey was actually the first state to allow statewide administration of buprenorphine by their paramedics. Again, it's the advanced life support that are hospital-based, in touch with those hospitals. The other law that was passed was the Naloxone Leave Behind, which this allows EMS to not only administer naloxone to somebody who suffered a suspected opiate overdose, but then to offer, they must offer to leave naloxone with the patient or the family if they're at risk of overdosing again, which is a huge advancement. Along with that naloxone, they also will leave, they must leave harm reduction services as well as treatment and recovery resources as well. Next slide. So one of the programs that we're very proud of that's drawn national attention is, again, the medication-assisted treatment, or buprenorphine. We started with a pilot program prior to the law. We had an executive directive that allowed a pilot program of the buprenorphine. Started in August of 2019 with one specific facility. They treated just over 150 patients. And the idea behind how they treated the patients was, once they were called to an overdose, they would administer naloxone to reverse the overdose. Once the patient was awake, they would do what's called a COWS score to evaluate the patient's withdrawal symptoms and so forth. If the patient met a certain criteria, they offered to administer buprenorphine and make them an appointment for follow-up with the clinic within 24 hours. With that, they had fairly successful rates. With the patients that accepted the buprenorphine, of 130 or over 150, 36% of them actually attended that first meeting, that first appointment within 24 hours. And then what's particularly interesting was that of those 36 patients, almost 70% of them still were in the program 30 days later. So it's proven to be a huge success, and it's expanding out to other programs as well within the state. Next slide, please. To augment that program and expand it out, like we said, through the advanced life support, we have our Naloxone Leave Behind program, and we've generated a lot of support through our partners at Department of Human Services. We were able to help secure naloxone. One of the pushbacks, I should say, that we had from Mris Medical Services is a lot of them are volunteer or they're limited budget. So it can become very costly to not only administer naloxone, but also to do leave behind. So we're able through our partners of the Department of Human Services to create a program where they're able to get naloxone to administer out to patients on a regular basis. From the Department of Health side, we've generated resources to help cover harm reduction and make sure that they have those materials to leave behind with the patient. So when the patient, if and when that patient is ready for recovery resources or treatment resources, they have them in the palm of their hand. And it's by brochures. We have magnets that go up on the fridge. So they are tangible items that can be left behind with the patient. And then also treating EMS about harm reduction services and the harm reduction centers around the state, and understanding the use of the harm reduction centers and being able to refer patients to them as well. This is a picture of the actual kits that we passed out to our EMS providers that allow them to leave behind, again, some of those materials. Next slide, please. So moving forward, some of the initiatives that we're looking to do is expand the use of buprenorphine beyond the pilot program into multiple other programs, advanced life programs around the state. That's currently underway. Expandment of treatment and harm reduction services through EMS. We've done that through a fantastic partnership with our Attorney General's office and again, our Department of Human Services. One of the biggest things, and I repeat it again, that a lot of EMS providers, they're taught to treat the physical symptoms. So the idea of referral to recovery resources and harm reduction resources is a relatively new concept. So it takes time in trying to evolve in that. And we've had tremendous support through other offices, state offices around the state. And it truly, truly is a team effort. We've expanded, again, the availability of naloxone through the Naloxone Leave Behind initiative that was started by our DHS partners. And then again, greatly expand first responder training. And this is not only through our 5 Minutes to Help program to teach about SUD, as well as buprenorphine and medication-assisted treatment, but also, again, about mental health and mental wellness, not only on the patient to understand where the patient is, but amongst the providers themselves. EMS has a very high rate of stress and obviously PTSD and just mental health in general. So understanding that they're vulnerable themselves is critical, because obviously you can't take care of the patient unless you take care of the provider. So we always tell them good provider care is good patient care. So it's making them aware of their own vulnerabilities and understand how compassion fatigue and stress of the job can actually relate to how they treat their patients. So understanding themselves better and their partners and their fellow clinicians will obviously result in a greater patient outcome or greater patient experience. So we've really tried to stress that and expand the programs in that as well. Next slide, please. This is just my contact information. If you scan that QR code, it will send, will link you to my email. If there's any questions on emergency medical services or the SUD program or 5 Minutes to Help program, please don't hesitate to reach out, and we're happy to answer any questions during the chat as well. Thank you for your time, and thank you for this opportunity to speak with you.
Thanks so much, Tim. And thanks to all our panelists. I know we're coming very close to the end of our time, but I do want to try to get some questions in. So we're going to go ahead and launch the participant evaluation. If you could complete that now about today's event, we would appreciate it. And Dr. Baird and Dr. Caldani, Dr. Baird, I'll start with you. There's a lot of questions. If you could just clarify what was discussed between the different types of medically assisted treatment, Suboxone and buprenorphine, what's the difference between them? Mm-hmm. And also, how long do patients stay on these types of treatments? What can people tell their patients and the families of their patients?
Yeah, no, all good questions. And my apologies, Angela, I was cheating. I was reading the chat, so I saw all the questions, and there were a lot of questions from a lot of people on those topics. So basically the 3 different types, let's start with naltrexone, or what's called Vivitrol. That would be an injection in your rear end every month, every 30 days. This blocks the opioid receptors. This prevents opioids from binding. Bottom line is patients who are highly motivated tend to be on Vivitrol. Patients struggling with detoxing, withdrawal symptoms, cravings tend to do better with buprenorphine products or methadone. But naltrexone as an injection always remains a viable opportunity. And the sort of contrast to that would be the methadone side of things, which fully binds to the opioid receptor. So it alleviates and gets rid of cravings, and it helps prevent overdose. And in the middle, there's buprenorphine, which kind of does both. It both activates the opioid receptor, but also blocks it very well. So hopefully that's not too confusing. The question I always get asked and seems, to be a common theme is how long? How long do people need to be on these medications? So it's a very easy answer. And I think we have to recognize, number one, with all the stigma behind addiction, the medications have just as bad of a stigma as all the other ones. Everyone has stories and opinions and such, but the fact of the matter is, if it's done right, these medications work so well. I'm going to use an analogy. If you have high blood pressure, do you ever ask your doctor, how long do I need to be on blood pressure medicine? Most people don't, but you should. And why do people get off of blood pressure medicine? Because they made lifestyle changes. They lost weight, they're exercising, they minimized salt in their diet. They did all those things that led to them having high blood pressure. So when do people come off MAT? When they're ready. That could be 6 months from now, that could be 60 years from now. There is no time limit on this, and stop putting a time limit on it is what I would say. Meet with your people, your patients, all these people, check in with them every month. How you doing with the medicine? How do you feel with it? Is it still helping you? Do you think it's still helping you? And patients approach me and say, I want to get off. And we talk about why. Do they have all these other things in line? Are they going to groups? Are they going to meetings? Are they employed now? Are they out on their own? Are there any major life changes? You don't want to disrupt the stress in somebody's life who's in early recovery. And so we're starting these medicines on people who are just coming out of detox or their active addiction, but also long-term. We need to think about long-term recovery. There was a lot of questions I also saw, and this will be the last thing I say, and I'll turn it back over to you, Angela. Have there been studies on people weaning off? And there have. And these studies just are not great, really, results. So I will quote one particular study, 2019 Journal of Psychiatry. They took 400 patients who have been on Suboxone for over 2 years, and in what they consider full recovery, negative drug screens for that period of time. And all 400 of them were weaned off. Half of them were weaned off in 30 days. Half of them were weaned off over 2 years. Of the patients who were weaned off in 30 days, half of them relapsed almost immediately. So these are powerful medications, and patients who were medication-only treatment, really need to have a discussion to make sure that they're getting that peer recovery support, that they're doing okay. But the bottom line is there is no time limit. Meet with your patients, check in with them, and have that discussion on a monthly basis.
Thanks, Dr. Barrett. And I know that we've come to the end of our time. So I'm just going to go to all of our panelists with one last question. Dr. Caldani, if you want to start, there's a lot of misinformation and stigma surrounding this issue. I know Dr. Barrett, spoke about it, you spoke about it, Tim spoke about it, but what is the one, final thought you would like to share with all our attendees on how they can play a role in clarifying and explaining the need for this?
Well, I think a forum like this is really important to provide the education about the facts, so that people understand the facts. And the people who understand the facts could be the patient, the client, the family members, as well as the clinicians involved. And the more that we understand these nuances, the better that we can provide that information for people to make an informed decision. And I think Dr. Baird did a wonderful job of explaining, for example, the very difficult question of how long do I need to be on the medication? It's a very individualized approach. And being able to have people accept that for every person it is different, that there is no one answer. I believe doing that really helps to decrease the stigma and helps to normalize the conversation, just like we would do it for any other disease or disorder, whether it be mental health disorders, people who are on antidepressants. Some stay on them for life, some do not. It is an individualized approach.
Thank you. And Tim, I know you come from a different perspective, but any last thoughts you wanted to share with the attendees?
Sure, just a little bit of background with the Naltrexone Leave Behind program, and I know there's a lot of interest in that. Basically, any of the agencies can carry it. It's funded through a federal grant, and the agencies can apply online for that. Our basic life support, there was a mention of police. Police are typically first responders. They can also be EMTs as well. Paramedics are strictly hospital-based as the advanced life support. They can carry the buprenorphine based upon their program as well. So we're trying to expand out the Naltrexone Leave Behind for all of the agencies, not only police, but also police, fire, our EMTs, and our paramedics as well. We have a really good working relationship with all of our agencies. It's just trying to get them on board, again, because there is so many of them. But again, they've been extremely supportive, and again, a lot of interest in that as well.
All right, thanks so much. And Dr. Baird, I'll just leave you with the last comment of the day. Anything additional to share with our attendees?
No, thank you for your attention, really. If we're going to tackle this opioid crisis, and a lot of people mentioned it in the chat, now we're seeing the stimulants come in. This is a disease of society. It involves all of us doing our best to get these patients the resources they need, the care that they need, the follow-up that they need, the support that they need, and to encourage each other and take a stand against stigma. And I would say, if you hear somebody make a snarky comment, call them out on it. And, the only way, we're going to get through this as a community is to do it together. And, thanks everybody for your support and again, your attention. And that's all I have.
All right, thanks. And so important as we continue to address the opioid crisis, but as a whole, the addiction crisis that we're facing as a state. So I want to thank all of our expert panelists for being with us today and sharing such important information. Appreciate your time and your preparation for this activity. And also I want to thank all of our attendees. Appreciate you guys tuning in and getting this information. I know there are some questions that we haven't been able to ask our panelists, but go ahead and send those over as an email and we'll try to get you answers to those questions. But I want to thank everyone again for their time today and enjoy this summer day. Have a good day, everyone.